Today's lecture is going to be on the knee joint. When we're looking at the knee joint, it's primarily considered to be a hinge joint. And this hinge is going to it's considered to be called a tibiofemoral joint. And it is going to be the connection between the femur and the tibia. There's also a patellar femoral joint, which is classified as an arthroidal classification, which simply means that the patella is going to have a gliding nature along the femoral condyles. When we're looking at the knee joint, even though it is considered to be primarily a hinge joint, it does have internal and external rotation that occurs during flexion, and we'll talk about that later in the lecture. The first thing that we'll look at is going to be the patellar surface, which is located on the femur. And this patellar surface is composed of articular or hyaline cartilage, so it's very frictionless and smooth. And the posterior aspect of the patella will also have the articular cartilage. What we also see is going to be condyles, so we'll have the lateral condyle and the medial condyles that are composed of articular cartilages. And then we'll also have the lateral condyle of the femur and the medial condyle of the femur. And these again are just to provide frictionless and smooth flexion and extension between the femur and the tibia. One other thing to make note is that the fibular head, located here, does not have any articulation with the femur. The fibular head, or the fibula itself, its main job is to provide muscle attachments primarily for the ankle and foot joint. So the first part that we're going to look at is going to be the enlarged femoral condyles. These femoral condyles that we can see here, we see the medial femoral condyle, and then we see the lateral femoral condyle. And they aren't directly articulating with the tibial, the medial or lateral and medial tibial condyles. They're going to be located or going to have structures such as the medial and the lateral meniscus, which are composed of fibrocartilage, which provides cushion and support. We also see structures such as the posterior cruciate ligament here. This posterior cruciate ligament is going to attach to the posterior surface of the femur and then insert into the posterior aspect of the tibia. And then we have the anterior cruciate ligament that crosses in front, and the anterior cruciate is going to connect the anterior surface of the femur, or the posterior surface of the femur, to the anterior surface of the tibia. One of the most important aspects is that the medial side, so the fibula is always the non-weight-bearing side, but the medial side is always going to bear most of the weight, especially in a flexed knee position. So as mentioned earlier, the fibula has an important aspect in that it serves as attachment for different knee joint structures. In particular, we're going to look at the fibular collateral ligament. So we have a ligament on the lateral surface. The fibular lateral collateral ligament is also called a lateral collateral ligament. Again, it does not articulate with the femur or the patella and is not classified as part of the knee joint. So when we're looking at stabilization, particularly when we're looking at ligamentous structures, the ligaments are going to provide static stability. So basically what we're looking at is that when the leg or the knee joint is in extension, then the ACL, PCL, the medial collateral and the lateral collateral ligaments will provide stabilization. During a flexed knee position, what we see is the quadriceps and the hamstrings are going to contract to produce some sort of a dynamic stability. And we usually refer that in a ratio. So the quadricep strength to hamstring strength is going to be in a 3-to-2 ratio. Or you can think about it in the aspect that the quadriceps should be 1.5 times as stronger than the hamstrings during any type of 1 repetition max strength test when you're isolating the quadriceps or the hamstring. Again, as I mentioned earlier, the meniscus, we see here the medial meniscus is going to have more of this open C. The medial meniscus is also a little bit larger and thicker because it's going to bear the majority of the weight, versus the lateral meniscus, which has more of a closed C shape. It does not bear the majority of the weight. And these meniscus structures are composed of fibrocartilage, which their main job is for cushion support or shock absorption. Their job is to help deepen the tibial fossa and also enhance the stability of the knee joint. So when we're looking at the knee joint, what we're particularly looking at is we consider the knee joint to be a synovial cavity. Synovial cavity means that we're going to have this synovial membrane that's located here in the purple. And this synovial membrane is going to encapsulate. So everything located in purple is going to be the synovial membrane. It will have cells that are going to produce synovial fluid. This synovial fluid is important to allow for the patella to move in a frictionless, smooth aspect. And it also allows the synovial fluid to be absorbed and reabsorbed by the meniscus during any weight-bearing activity. What we also see are different structures called an interpatellar fat pads, mostly located in the anterior surface of the knee, but we do see them in the posterior surface. But it's important in the anterior surface that we have these interpatellar fat pads for cushion and support. We also see a series of different bursae, and bursae are simply synovial fluid sacs. Usually in the human body we see, or the knee joint, we see anywhere between 8 to 11 synovial bursae, which contain synovial fluid. The primary ones are going to be located more in the anterior surface, so around the movable part of the patella. So we have the prepatellar bursa, the interpatellar bursae, which is below. But we also have bursae located in the back where we see the gastrocnemius connecting into the femur on the posterior surface. The top picture is going to represent the different lines of pull that are going to be coming onto the patella. So over here on the left-hand side, we're going to have the vastus medialis, which is going to come down. It's going to hit the top portion of the patella and the medial surface, and then eventually it's going to go into the tibial tuberosity. We can see the main rectus femoris tendon. It is going to come down to the top surface of the patella, through the center, and then again attach into the tibial tuberosity. And then we have the vastus lateralis, which is going to hit the top surface and also connect into the lateral surface, and then finally terminate into the tibial tuberosity. The connection is important, so when it provides different lines of pull for the patella. So when the quadriceps are contracting, the patella moves up. So when we look at the vastus medialis, it will provide more of a medial and upward pull. The rectus femoris should primarily be an upward pull. And the vastus lateralis will provide a lateral and an upward pull on the patella. So in this semester, we've been talking a little bit about the myofascial tissue. And just as a reminder, when we're looking at the myofascial tissue is going to connect from the toes all the way to the top of the head. Myofascial tissue, when we're looking at this picture, we're going to see the extensor digitorum muscles, how it's connected into the anterior tibialis. We can also see how the rectus femoris, vastus lateralis, the IT band, vastus medialis, these are all going to play a role in the different lines of pull, not only on the anterior tibialis, but also in the extensor digitorum. So any tightnesses that are going to occur around the knee joint are not only going to affect the lower half, anything closer to the foot, but it's also going to work its way up through the hip joint, which we'll talk about in the next chapter. This is just another illustration of how the myofascial tissue can affect the lower half of the leg. So here we have the bicep femoris long head. We can see the myofascial tissue extending into the fibularis or peroneus longus tendon, which then again, the peroneus brevis is going to connect into the fifth tuberosity, and the longus will connect into the other side in the medial cuneiform. So any tension that develops on the bicep femoris, on a myofascial, it will travel down and create tightnesses or dysfunctions through the ankle joint. So when we're looking at the different types of cruciate ligaments, we're going to be looking at primarily the ones that are going to help provide static stability to the knee joint. As mentioned earlier, we have a lateral and a medial meniscus. The medial meniscus is going to be a little bit thicker. Both of these are composed of fibrocartilage, which its main job is going to be for cushion support and shock absorption. The first one we're going to look at is going to be the anterior cruciate ligament, which is this one right here. This one is the one that usually is the most damaged. It crosses within the knee from the posterior aspect of the femur and crosses over and connects to the anterior surface of the tibia. So the anterior cruciate, as mentioned, is one of the most common serious knee injuries that occur. It usually involves rotary forces associated with foot planting or cutting, sometimes with hyperextension. We also see it with any type of violent quadricep contraction, which causes the quadricep would cause the tibia would be pulled forward on the femur. Their stability in respect to stability, their job is to provide an anterior and posterior stability, and also the rotary stability of the knee joint. When we're looking at the next one, the posterior cruciate ligament, which is located here, this is a very strong ligament. It connects from the posterior surface of the femur to the posterior surface of the tibia. Usually this ligament involves falling onto the tibia in a bent knee position, and it's providing stability of a posterior shift of the tibia. So if your knee was bent and you fell, hit your tibia, and the tibia was driven back into a posterior position, we most often find that the posterior cruciate ligament can be hurt. When we're talking about the knee joint, the first one we're going to look at is the lateral collateral ligament, which is over here. You can tell it's very thin. So this lateral collateral ligament is thinner. It's not as thick as the medial collateral ligament. And when we're looking at the position of the knee joint, in reference, I usually use the tibia to describe this, but if you were to tear the lateral medial meniscus, then your knee would then move more in an AD or adducted position. So it helps stabilize the knee from moving into a grossly exaggerated adducted position. The MCL, or what they consider to be the tibial collateral. I usually refer to it as the medial collateral ligament. You can see in its size, it's very thick, it's very long. In supporting the tibia, it's preventing the tibia from moving in an AB or an abduction position. And this one can be strained most often in injuries such as skiing. So usually with knee injuries, it usually involves some type of a valgus force, which just means some external forces that are coming in into this picture. And usually what we see is there's going to be multiple parts that are going to be damaged. So if you were to receive a lateral blow, we can see here the first one that's being injured is going to be the ACL. The lateral blow is going to cause a rotary type of movement through the ACL. And then usually what we see in this case is then the femur is going to slide across the meniscus once the ACL has been ruptured, and it can usually cause any type of micro trauma or tearing in the medial meniscus. And you can see in this case that the MCL, or the tibial collateral ligament, the blow was hard enough to not only rupture the ACL, the femur sliding over the top of the meniscus and causing microtrauma, but it also in this case has ruptured the medial collateral or tibial collateral ligament. Most knee injuries that involve any external forces or high amounts of forces are going to usually cause more than one injury to a structure of the knee joint. So when we're looking at Q angles in individuals, we're going to take first a couple of measurements. The first one we're going to look at is the anterior superior spine. And then this red line is illustrating how we're going to draw a line down through the center of the patella. And then our second landmark is going to start at the tibial tuberosity. And we're again then going to go from the tibial tuberosity. And we're going to go up through the middle of the patella. And we're going to be looking at the angle that these two lines create. And what we're really looking at with the Q angles are going to be overall patella health. So if your patella is shifted more laterally, which is most often the case, then when you take the measurement from the tibial tuberosity up through the center of the patella, you're going to have a smaller Q angle. So normally what we're looking for is somewhere between 15 degrees or less in males and 20 degrees or less in females. We also know that the hip structures of females tend to be slightly larger for birthing purposes, and that can also affect the overall angle, or what we consider to be the Q angle. And primarily what we're looking at in this illustration is going to be your overall patella health. So there are some things that occur if you do have a wider than normal Q angle, and usually this occurs mostly in the lateral position, and particularly when we're looking at the lateral position is the dominance of the vastus lateralis, or the widening of the Q angle. Usually we get the patella that is going to shift more laterally, which causes some type of subluxation, which is a partial dislocation of the patella, or in worst case scenarios, we can see a complete dislocation. Quadriceps tightness that can occur can put excessive pressure on the patella. We usually call this patellar compression syndrome. Overdeveloped quadriceps, we know that the rectus femoris, vastus medialis, and vastus lateralis all are going to connect into the tibial tuberosity. And sports such as repetitive movements such as road biking and quad dominant movement also can cause this patella to be compressed and cause irritation of the bursae underneath the patella, or worse yet, groove into the condyloid of the femur. Any ligamentous injury, so if you were to rupture an MCL or an ACL or an ACL, also can change your overall health of your patella. And finally, the last one is chondromalacia, which is more a genetic anomaly. Basically, if this was the posterior surface of your your patella, the chondromalacia forms, the articular cartilage breaks off in a form of ridges, and those ridges will then glide along the patellar surface of the femur and cause microtrauma through the articular cartilage. And finally, when we're looking at the pes anserinus, this is often misdiagnosed, or this can be misdiagnosed in, sometimes it's often misdiagnosed as an MCL injury, and usually it's an irritation, not so directly in the middle of the femur and the tibia where we see the MCL cross, but slightly lower. And usually this is associated with three things. We see over here, we see the gracilis tendon, the sartorius, and the semitendinosus all come down distally and attach. Then we see the MCL ligament attaching, and right underneath we have a bursae. So what happens is this usually becomes irritated. The bursae becomes irritated. It mimics an MCL pain, usually associated also with tightness through your gracilis, your sartorius, or your semitendinosus. So this aponeurosis that is being formed sometimes get irritated, and it'll mimic an MCL pain. So finally, when we're looking at the hamstring group, just as a reminder, is that your knee joint does rotation. So when we're looking at the bicep long head and short head, or the bicep femoris, especially the long head, we're going to see that the bicep femoris is going to do external rotation, where the semitendinosus and semimembranosus are going to do internal rotation, or what we consider to be medial rotation. So what we have here is a picture of simply two things of an interlocking mechanism. We see the myofascial tissue is going to connect to the femur of the gastrocnemius, and then we see the semitendinosus and bicep femoris that are going to interlock and attach to the tibia. And this interlocking mechanism, if this myofascial tissue becomes tight, causes the femur to be pulled down and the tibia to draw up, which creates a lot of tension in the meniscus. The other aspect that we're going to look at is the classic textbook has that the hamstrings are going to terminate, all the hamstring groups are going to terminate at the ischial tuberosity. But on a myofascial connection, we're going to see that the myofascial tissue actually goes into a sacrotuberous ligament, and then eventually into a dorsal sacral ligament, and attaches to the opposite posterior aspect of the pelvis. So again, when we're looking at the classic origin of all the hamstring groups is going to be the ischial tuberosity, but on a myofascial, we can see that the myofascial tissue continues past the sacrotuberous ligament. It connects through the sacral fascia, and then the next section is going to be the dorsal sacral ligament or myofascial ligament, and then eventually it's going to attach to the posterior surface of the pelvis, or the crest of the pelvis. So basically what that's telling us is there's an indirect relationship to an individual's tight right hamstring This myofascial connection can then affect the change in position of someone's left hip. So we do have that cross. We also have the lower back here. We have all of the erector spinae, quadratus lumborum, myofascial tissue coming down through the sacral fascia. So this can also, any changes through these areas could then vice versa change the relationship of what can occur in someone's hamstrings.